Like double. Wow. Car?
I didn't think I saw you come in with anything.
No. Terrible. Who's talking about substance disorders? Right. Oh, no, my coffee. Thank you for my coffee.
I'm having a meltdown right before.
Oh, boy.
I love it.
We are crazy, us humans. Somebody's got to turn it off. What does that mean? Sorry, people. Patricia, you're going to be first.
Oh, okay, fun.
So you have a tiny bit of heads up.
Thank you. I appreciate it.
Thank you, Joe.
Look at these beautiful faces.
Everybody have pajama tops on in there on that video?
So I was just commenting that I left my coffee in the car and I'm beside myself. So there we go. I think I'll survive though. I'm going to give it one more minute just for Kevin. And Brandy, that means you're going after the didactic.
Okay.
Okay?
Okay.
All right.
You each the cases.
Okay. But if you're already projecting, you want to be the projector of those things?
Oh, okay.
Share your screen just the whole darn time. Okay, so let's get started. We can start with some introductions and then we'll go into our little spiel, and we've got two great cases today as well as a fabulous didactic. So let's do our round of who you are and where you're from and what your role is there. And we'll start with Patricia.
Good morning. I'm Patricia Walters. I am a behavioral health specialist with population health with the community care teams. I work in two hubs. One is the Hamilton 3080 hub and the other is the Blandon hub in Berks County.
Okay, keep you busy, right?
Yeah, a little bit.
Welcome, and thanks for bringing the case today. Really excited about that. Jill.
Me?
Hi. Oh, Which Jill?
Oh, Jill. Oh, Jill, not Jillian. Go ahead.
Hi, Jill McCambridge. I am Behavioral Health Clinical Coordinator with Population Health Community Care Team.
Welcome, Jill.
Thank you.
Lori, you're up.
Hi, Laurie Widener. I am Behavioral Health Specialist with CCT.
And welcome. Hi, Erica.
Erica Pinella, Lehigh County Drug and Alcohol. I work as their CRS and liaison for treatment trends.
Great to have you here. Valerie, good morning.
Good morning, everyone. Valerie Guerra, Behavioral Health Specialist for Population Health Community Care Team.
Hooray. And Kevin.
Good morning, everyone. Kevin McNeil. I'm a family physician practice here in Hamburg.
Yay for Hamburg and Kevin. Hi, I'm Elisa.
Good morning, everyone. Yeah, Melissa Taveras, faculty member and PACMAT caseworker.
Wonderful to see your face, Elisa. Good morning, Heather.
Hi, I'm Heather Cromer. I'm the Behavioral Health Specialist with Population Health CCT team.
Wonderful to have you here too. Hi, Shelley.
Unmute me. Not awake yet. Sorry, didn't unmute myself. Shelley Steiner. I am the program director at Peer Drug and Alcohol Services, and I am also in private practice. Hi, everyone.
Hi, Shelley. Sophia, good morning.
Good morning, everyone. Sophia Harbove here, BHI PACMAT caseworker.
And wide awake so far. Good. Jillian.
Good morning, everyone. Jillian Beecham, PACMAT faculty and co-director along with Abby. And great to see everyone.
Wonderful to have you here, Jillian. Christopher.
Good morning, Christopher Nine, Behavioral Health Clinical Coordinator with the Community Care Team.
Wonderful. Welcome, Nyan.
Good morning, everyone. I'm Nyan Beery. I am the project manager for PACMAT at Lehigh Valley Health Network.
Couldn't do it without you. Glad to have you here. Jessica.
Good morning. I'm Jessica Morris at the Center for Women's Medicine, Valley Health Partners.
Terrific to have you, and congratulations on your new role. Yes? Jazz, 832. Look at that, it's a jazz. Jazz.
Judy from Nurse Care Manager from Valley Health Partners.
Hi, Judy. Let's see, that's Melissa again. Liz. Liz? I don't hear you, Liz. No, you're not on mute. Let's try Erica.
Hi, good morning.
Good morning, Erica. Can you share with us your role and where you're from?
Yes, I'm a behavioral health specialist and I'm working through the Lehigh Valley Health Network. I cover the Fogelsville practice, Macungie, Otterfield, Cetronia, and Trexlertown.
Oh, wonderful to have you here. You've got your hands full. That's
yes.
Michelle.
Hi, good morning. Michelle Zapali, Behavioral Health Specialist with the Community Care Team, and I'm in between practices right now.
Great to have you here. A little bit of stability. Amy.
Good morning. Amy Smith, educator in the Department of Education, Lehigh Valley Health Network, working with the select medical students. In my background, I'm also a site reviewer for the Society of Simulation in Healthcare.
Always a pleasure, Amy. Let's see, Tom.
Hi, good morning. Tom Michaels, Manager for Behavioral Health and Social Work in Population Health.
Good morning, Tom. Stacy.
Good morning, Stacy Cook, Manager of Behavioral Health Integration through the Department of Psychiatry.
Good morning to you. And I think that's Frank, Mr. 3904.
Good morning, Franklin Ortiz, Behavioral Health Clinical Coordinator for Valley Health Partners, working at the 17th Street Community Practices.
Good morning. And let's give Liz's iPhone another chance. We're really excited to have Liz's iPhone, and if at any point you can show your face and let us know who you are, welcome. And if that's not what's happening today, still welcome to you. Let's do our go around in here. We'll start with Brandy.
Hi, I'm Brandy, and I'm here at Neighborhood Health Centers. I'm actually new to the team and the entire organization. I am part of the COE team, and I'm presenting one of my cases today.
Really great to have you here.
Thank you.
And then I'm going to go over to Jasmine.
Hi, I'm Jasmine, and I'm part of Project Echo and the COE team at NHCLV.
And Naomi.
Hi, I'm Naomi. I am the Echo Specialist and Integrated Team Care Manager here at NHCLV.
And I wanted to take a minute to say thank you to Naomi. This is her last Echo with us here at NHCLV, where she's been so helpful, keeping us organized and moving forward. And, give the whole team here a chance to wish you well in your new role.
Thank you.
Thank you so much. Okay, I saw a little bit of Liz. Liz is in the car. Don't try and do anything dangerous, Liz. All right, we do have two great cases. Jasmine, if you've got our fancy spiel, let's get started with that. And then Naomi, I'll ask you to shut the door just because people are going to start to come in. And I want to also, while we're having some group time here, just keep Angie Callistra in your thoughts. She had a family tragedy last night, and use all of our best wishes. So for Angie. Yeah, so the little blurb, I think, mostly just says, please don't use anybody's names, keep it confidential, and star something or other to mute and unmute if you're on the phone, but most of you are on the computer.
Share a general reminder to maintain confidentiality by not releasing any personal health information of the individuals being discussed today. Please mute yourself when not speaking by clicking on the microphone icon in the bottom left corner of your Zoom screen. Audio participants, please dial *6 to mute and *6 to unmute. Prior to speaking during this clinic, please introduce yourself by saying your name and location. This allows those who are using audio to follow the conversation as they cannot see who is speaking.
Ready?
Still
Okay. Pardon us while we experience technical difficulties. Very glad to have this wonderful group of behavioral health specialists for our first case with somebody that I know well, and we're a bit stumped. So very much want all of you thinking about how to get this one a little bit unstuck if possible.
Hopefully.
Yeah.
Yes.
We're almost there. Okay, Patricia, you're up first.
Hi. All right, I think I'm unmuted, and thanks for making this such a beautiful PowerPoint. I didn't get that far with this.
Yeah.
The case that I was bringing up today, it is a Mosellum Springs patient. I am working on the behavioral health side of things, and Dr. Clugston is the physician treating the patient. So our basic needs for the patient today are help with the non-medication side of treatment. He is not currently aware that we're presenting and did not help develop the question, but the strengths for our patient: he is knowledgeable regarding recovery services, has support from his mother, and is very artistic and creative. Our big question is, we are looking for assistance in encouraging him to engage in recommended and structured sober support services. He has been a little bit tricky for us, so any recommendations in that realm are welcome today. He began treatment with Dr. Clugston in May of 2020, and he had initially sought treatment with PA counseling services in Berks. He was recently released from incarceration and was paroled to his mom's home in Fleetwood. He had initially noted to all of us that he had state parole sentencing until the year 2030, and presented very reluctant in the beginning to sign any information for parole, as he said, "I want to keep my treatment separate from my legal involvement." He was unemployed at the time of intake, has limited transportation, and no recovery supports in terms of outpatient therapy. He wasn't attending any 12-step, but he did tell us that he had peers in recovery, but was very informal in his meeting with them. He's residing with his mother, had completed high school on parole, and at the time, unemployed. His drug screens, Dr. Clugston says all his drug screens have been consistent. He has had no opiate relapse, and he did note that he's had intermittent use of methamphetamine. He reported at the time of his intake a couple instances that he had been using alcohol. He initially noted about 3 beers a week, and his date of last use for opiates was 2019. He had a period of relapse. He noted off and on use of Suboxone since 2018, and also reported a history of marijuana, cocaine, and methamphetamine. So he, treatment-wise, like pretty much medically, he's not in a very bad shape. He's doing pretty well, but his medications right now are the Suboxone, hydroxyzine, and he does have Narcan. Oh, and there's all his checklist that. Okay, so he has been involved in previous inpatient treatment placements. He had previous stays with both Pyramid and Teen Challenge. He had previously been involved in NA meetings and had contemplated becoming a certified recovery specialist. He had agreed to allow Dr. Clugston in a recent visit to speak with his parole officer. And so she did, and in the conversation, his parole officer noted that he is requiring the patient to be engaged in like more structured treatment supports because their concern is his original charges were related to substance abuse. The patient notes, though, that he does not wish to attend any treatment, especially in the Reading area. He says Reading's a very big trigger for him. We've tried to make referrals for CRS both through the PACMAT grant and Berks County, and he did not respond to the outreaches made. And he has basically, in his last visit with Dr. Clugston, asked if 12-step meetings could be considered enough structure for him. So he's definitely expressing a concern regarding engaging in anything beyond that. And Dr. Clugston, as she said, for me to note in the presentation, she doesn't necessarily want to have to police him, but this is a big question right now. He notes that he's motivated by his desire to not return to prison and his family support. His parole officers noted concerns. He has a current relationship with a girlfriend who's not in recovery. The parole officer said that is a big red flag for him. And they also noted that the patient has engaged in some behaviors of concern like he used to. One of the issues, they recently put him on an ankle monitor because, as the patient said, I went to New Jersey and they found out. So they're watching him a little bit differently. So parole is definitely monitoring him a little more strictly. So the biggest goals for him right now is he's been consistent with his Suboxone use. So obviously to continue that. Dr. Clugston was monitoring him. I think like they were a little bit maybe at once a month, but now she wants to see him every 2 weeks while he's his monitoring with parole has changed and some things are a concern. And we definitely want to encourage him to engage in Narcotics Anonymous for recovery support.
Okay, Jillian, peer summary.
All right, so this is a 39-year-old Caucasian male who's a patient of Dr. Clugston's at Moselle Springs and began treatment with her in May of 2020 after his recent release from being incarcerated. Is currently on parole, and one of his major goals is not returning to being incarcerated, so that's a big motivator. And his parole officer has mandated some structured support services, but the patient is only willing to really engage in NA meetings at this time. He's staying with mom and notes that Reading is a geographic trigger for his substance use. At the time of engaging with Dr. Clugston was unemployed, limited transportation issues, and limited recovery supports beyond some informal contacts with peers. Reports intermittent methamphetamine, occasional ethanol use, occasional cocaine and marijuana use, with last opioid use in 2019, and intermittent Suboxone use since then. Currently on Suboxone hydroxyzine, has a naloxone kit, and only other medical issue is that he's Hep C positive. Has had prior inpatient treatments with Pyramid and Team Challenge, prior NA meeting involvement, and has even contemplated doing CRS training.
Thanks, Jillian. Did that about capture it, Patricia?
Oh, yes, very nice.
Awesome. So let's toss this out to our wonderful group and the questions that we have, and a reminder for people that our 2 rounds of questions start with just questions for clarification, things you're curious about this patient, what do we want to know, and then we'll go into solutions. But we'll start with just the clarifying questions. And I saw a question from Shelley, and I lost it. It was here someplace. Who prescribes the Suboxone?
Oh, Dr. Clugston does.
Yeah, and she's one of the family docs that was at Blandon, now at Moselle Springs, correct? And she's wonderful. We'd love to have her here, but this isn't a good time for her. All right, more questions from our group out there, and you can just say them out loud. You don't have to put them in the chat.
Patricia, my question is the girlfriend, was she ever engaged in any kind of substance abuse?
In terms of treatment or just behavior?
She engaged also in any substance use as being like, you know, someone that also used at one point in time?
Oh yeah, the parole officer is identifying that the patient's girlfriend is currently using, yeah.
And what was one of the reasons, did he ever give a reason why he wanted to engage as a CRS?
Not really. There's been, in discussions with him, there's certain things that he doesn't go too into. But he did say, you know, he was contemplating that in the past, but he didn't give a whole lot of background as to what happened.
Thank you.
Sure.
Erica, I think you had a comment along those lines too. Did you want to ask a question?
So I just found it really interesting that he was interested in becoming a CRS, but he will not engage in CRS services. There's definitely a reason why. And as you were talking, Patricia, about not wanting to go certain places, I find it, if he doesn't want to talk to clinical about what is really going on, why would he want to talk to a CRS about that? But what he probably doesn't understand is we don't have anything to do with that. And I like to specialize in those resistant individuals that have no inclination to talk about anything. Oh, that's fine. Let's why? You know, so he interests me only because he is so resistant, because I remember being right there and not wanting, they didn't have CRSs when I got clean, but it's just really interesting to me that he doesn't want to have anything to do with it, but he does, but he really does. So anything that I could do to help with engaging this individual, I would absolutely kill for the chance of that one, because I love it. I love those ones.
Right, sounds like a good challenge, right? What a great case for a challenge. Thanks, Erica. What are a couple more questions from our group here? What do you want to know about this?
I'm wondering, does he have any structure to his day at all? Is he just BSing us? Because he's saying he doesn't want to go to Reading because it's a trigger, but he goes to the girlfriend who's a substance user. He says he wants to go into, training, but doesn't want to do anything. Is he just BSing us, sort of keep us off his back? And again, I'm trying to figure out, why should he change? He's living at his mom. He gets to see his girlfriend. He'll travel to Jersey. He'll do what he wants. Is he truly in? What's his motivation really to change?
Right. Hey, Ken. Ken is Liz's iPhone. Yay.
Oh.
Dr. Zemanek, nice to see you.
Oh. I didn't know that's what has been bought by my wife. I don't know.
All right.
I have a quick
more
question.
Go ahead. Go ahead.
No, go ahead, Franklin. You're good.
Just wanted to know, since coming out of prison and being on parole, do we know his longest time without using? Because it sounds like he wants to change, and has he been successful, and how long, and that kind of stuff. I just want to know, kind of like what Dr. Zemanek said. I just want to know, if he really wanted to change, did he do it, and how long?
I mean, he told us, I had it in my, in terms of, the drug of choice for opiates, his basic use has been like, he had a relapse in 2019, I believe I had noted, but yeah, he's been off and on. I don't think he's had no extremely, long periods of sobriety noted. But, he does talk significantly about a lot of his recent time was when he was incarcerated. So there was that factor. He hasn't had a lot of opportunity, I think, to be sober outside of the system.
Can you please clarify what you mean by intermittent Suboxone use?
Exactly that's how he termed it. So he would go on it for a little bit and, have some use period in there and then back on. So he wasn't consistent with it as he's been since May.
So he's been consistent since May?
Yeah, his following with Dr. Clugston's prescription, he's been consistent, and she said his UDSs have been on point for his Suboxone use, so she hasn't had any issues there.
Okay. Thank you.
Sure.
Right, maybe one more question from the group at large, and then we'll do our other little go around. Okay, I'm gonna call on our
I have a question.
okay, I was gonna say, let me call on my team, and I was gonna Lisa.
Any type of activity that he identifies. I know you said very creative, very artistic. Any type of engagement with any social activity that supports that.
Well, the biggest activity that he discusses, there's two things that he'll discuss really enjoying and really getting a lot of fulfillment from. And one of them that he's very excited about is tattooing. So he keeps hoping that he can somehow parlay that into, employment. I just think it hasn't necessarily gone there yet, but he does a lot of tattooing on himself and other people, and that's his definite creative outlet. And I think his other one, I believe there's kind of like the isolating activity of, video games, but definitely the tattooing is a huge thing for him right now.
Okay, so still unemployed?
He had a very short period of employment, I think, for just like a month or two, and he's unemployed again. Yeah.
Okay, thank you.
Sure.
Great. Thanks, Melissa. Sophia, any questions?
So I'm curious as to, what does his day look like? I mean, it just kind of sounds like he's very comfortable. He's living at his mom's. He can see his girlfriend whenever he wants. It doesn't really sound like, even though he's kind of on the Suboxone, I don't really see any internal motivation other than, there's external motivation. I mean, he's on probation or on parole, so he kind of has to. So what does his day look like? What does he do other than practice tattooing on lemons, I'm sure?
So he will, because of his limited transportation too, because he had a car, but it was having a whole lot of issues, so it wasn't exactly going to pass inspection. So yeah, a lot of his day was just kind of in-house by himself and, not doing anything necessarily outside of his mom's house very often.
Okay, so he's playing video games and hanging out with his girlfriend. That's pretty much it. And then attending NA meetings. Like, how frequently are those happening?
I'm not sure, because this last visit that he had with Dr. Clugston was probably just like a week or two. And that's when they were discussing, when parole said exactly what you guys are saying. You need some structure, you need something else to your day. And Dr. Clugston was discussing with him, the need to attend NA and how often he could do it. So this is just kind of a new situation in the last week.
Understood. Thank you.
Sure.
Kevin, do you have any questions from a primary care point of view? On mute. Still on mute. Oh, there you go.
How about now?
Now you're good.
What had happened? Sorry about that. So I was not from a primary care point of view, but I was very interested in what Erica was saying. He was it sounds like he was really engaged in NA in the past, and and that he was interested in being a CRS. So it sounds like he really had an interest and a commitment at one point, and now he doesn't. And I'd really like to explore that.
Jillian. Thanks, Kevin.
I'm more of a just thinking out loud than question, but I think we're all sort of circling back to the gap between his stated goals and what his day-to-day looks like. And I'm kind of curious how he feels about where he is right now. Like, is he actually content with that sort of day-to-day? It sounds like there's sort of a lack of structure, and he's resistant to structure. I'm just curious, does he express any discontent? Is there anything we could grab onto in terms of discontent with that piece? And I don't know if we have an answer to that, but I'm asking the universe that question.
Ken is speaking, but we cannot hear him. He's on mute.
That's a good point, Ken. Please say Ken. There you go.
Oh, can you hear me now? Can you hear me now?
Yeah.
No, can't hear you now though. There you
Okay,
go.
now. Okay. I'm wondering how much is he just BSing everybody? Because, you know, he says he doesn't have transportation, but yet he managed to end up using methamphetamine. So he's able to get that. He's able to meet with the girlfriend. He was able to get to New Jersey. You know, this guy is just blowing smoke up our butts. You know, he's, you know, there's no, I don't see any real motivation on him to change. You know, I think he gives us platitudes like, yeah, I want to be a tattoo artist. Or yeah, I want to be a counselor, but he doesn't do anything. I don't see any pressure to make him want to change. Like, when is the mom going to kick him out of the house? I mean, at some point, does she say, you know, you're going to have to take some responsibility here?
I agree with Ken. I think the mom is being an enabler a little bit here. And, you know, the girlfriend, if she's still using, he doesn't really have any motivation to do anything right now. He's just, you know, giving us all the right answers to stay out of jail.
Correct.
Can we talk to mom?
So we're switching into some suggestions now. The natural course of things, because we're trying to figure out, well, what are we going to do when and Erica, I want to sort of harken back to some of your first things that you were mentioning, that this ambivalence and incongruence, this is fertile ground and full of information. So how do we turn that into an opportunity for us as a team without shutting down into judging him for his resistance? Because resistance is part of the disease, right?
Right.
So how do we kind of maintain our own sort of equanimity so that we can use that incongruence and discord and where he's at to try and get in there a little bit? So let's think about that for a while with some suggestions. How do we get into that space of inconsistency and use that to help open him up in some kind of way? What do we think is going on with his resistance? We think about our the old school way of thinking about the motivational interviewing with the rolling resistance, but really getting into the ambivalence. How do we use that?
So my thought is, instead of, like, he's just used to people just telling him what to do, you know, being in jail, he's got a PO, probably tell him what to do. So what I grab onto is, what do you think a CRS is? What do you think? And then the stuff that comes along with it, you know, using that positive, instead of telling him what to do, what are the opportunities, you know, like, so tell me what you think recovery is. What does that mean to you? You know, and instead of telling him what to do, asking him what these things look like to him and working with that aspect of it, as opposed to like just one more thing, one more checkbox that I'm not going to check off. You know, how about you help me make those checkboxes?
Erica, that's a great suggestion that we've captured. What are some other thoughts by people? How do we get into that space of ambivalence and inconsistency? How do we get in there?
So I 100% agree with Erica. Is getting that CRS maybe to meet him at his next doctor's appointment, introduce themselves, have that conversation, see if they can build that rapport to try to engage with him. How you doing today? What's going on? Make a few phone calls, keep that person engaged as long as you can. That way, once you build that rapport, you have that connection, and then that connection can move that person out of ambivalence into a possible, oh, maybe I'll do this. You know, I think that's probably one of your best routes at this point with him.
Terrific. Other suggestions, resources? This guy's in Berks County, right?
Yes.
Mm-hmm.
I have a kind of comment question. I'm just wondering if overconfidence is something that has kind of come up within this? Like, he went to treatment, I know treatment. I wanted to be a CRS, I know what they're gonna say to me. Like, I'm wondering if that has become something that you're seeing, Patricia, when talking to him, and maybe that's an avenue to kind of explore a little bit.
Well, I definitely, yeah, it definitely came up with in everything, just even doing the initial intake and paperwork, because when I started to discuss with him his treatment history, it was very much like that. Like, yep, know that, been there, done that. So yeah, he doesn't make any qualms about that aspect of things, for sure.
All right, let's move to our crew here. Kevin, do you have any thoughts from primary care? Oh, unmute.
There we go. How about now? Abby, can you hear me? Yeah. Sorry about that. So one question I had was alternative structured programs. I don't know if we talked about that much here, but like what's available in Berks County, the Smart Recovery. What are our experiences with Smart Recovery? Are there other structured programs that we can do? That's because some people, for various reasons, don't like NA or AA or 12-step. So I'd be looking into other opportunities like that.
Great ideas, Kevin. Sophia, what are you thinking?
I mean, I kind of like to piggyback on what Erica said and just give him some power and just say, like, what does this look like to you? Like, what are your goals for treatment? But like, have him try to identify the steps instead of like, oh, I just want to be a tattoo artist. Okay, cool. Like, how do you get there? What do you think the steps are? How are we going to get there together? I think having him try to verbalize it instead of putting it out there and, satisfying us might uncover a little bit more as to his ambivalence, his resistance, and try to break down those barriers that he's put up.
Great, thank you, Sophia. Melissa, want to add anything there for a suggestion?
Definitely on board with Shelley, Erica, Sophia. One of the things that I wonder is, does he have a good connection with you, Patricia, that maybe he would sit and have some of these conversations with you and sort of explore, how to even identify some steps to achieve some of the goals that he's identified, or whether he would have a conversation about the girlfriend's use and the possibility of entering recovery, or anything, or anyone at the office that he has been open to speaking with.
Well, I mean, he's been good with speaking to me in the past, but honestly, I think in the last week when everything happened that, he showed back up to see Dr. Clugston with his ankle monitor, I feel like in terms of, because originally he was very much like, no, I'm not signing a release of information from my parole. I'm keeping these two worlds separate. And so in that last week, when he allowed her to actually speak to them, I feel like she might, and she sees him now every 2 weeks, she's going to see him physically. So I feel like maybe she might have a little more of an edge than me on that one, because that was a pretty big step, I feel like, for him to be able to say, yeah, you can speak with them. So, but you're right. It's definitely a conversation worth exploring.
Jillian, what's your approach here?
I'm thinking about a tool that Angie had described at some point, which is sort of talking the patient through these sort of 4 quadrants, starting, and I'll probably get this wrong, but sort of going through what don't you like about, like starting with his substance use, right, and everything that's come out of that. What has gone wrong, or what hasn't worked for you in terms of the substance use. What has worked? What do you like about that history, where you are? And then moving into the bottom half of the quadrants, which are next steps, right? Like engaging in some support services. What don't you like about engaging that concept. What's difficult about that? What doesn't feel right? And then ending with the fourth quadrant, which is what would be good. And I think ideally that helps you sort of march through the gaps and takes you from the what he's clinging to in terms of the aspects of his life that he sort of seems to be holding on to around his history of substance use that aren't letting him move forward, and then marching him through to where he what might be good about engaging in treatment, i.e., what are the things that might actually move him towards his goals. And maybe, a conversation just to explore a little bit about, what's in that gap, like what gets you to your future self that you envision, right? Being a CRS, being a tattoo artist, being in a good relationship. How do you get there? And it seems to me that we know, unless those ideas come from him, he'll never be able to do any of them. Right. So it's so frustrating because you see this guy and you're like, we know exactly what you should do, right? If we play the expert, which we are not. Just reminding ourselves that it has to come from him, that motivation, that even answering those questions, what's working, what isn't working, really have to come from him.
Yeah. So Stacy's bringing up the decision balance, and I think the key with this decision balance is you do start with what's great about not changing. What really would be the losses if you changed, right? So what do you like about the way things are right now? And starting there sometimes really gives people a chance to talk about where the resistance is without being in a place of having to get into that place of defiance, right? If you're opening that conversation, what's good about the way things are? And then moving on toward, well, what are the things that are not so good about where things are right now, about not changing? What are the downsides? Easier to start with the things that don't feel like they're welcome in the conversation, what he likes about it, move on to what's not so good, then what's not so good about change, and finally, what would be good about change. So this decision balance is one of the more powerful tools in the motivational interviewing toolkit. And it gives you a great chance to practice some of those affirmations and reflections, and how do you sort out the change talk, what sounds really stuck, but then how do you reflect things back that, and those moments where he sounds a little less stuck and a little more having insight in what kind of changes he could make. Just keep gently paddling the conversation in that direction, and this tool, I think, gives you lots of opportunity to find the patient's own words and own thought structures around change. So that's a great case, Patricia. Really tough. Yeah.
Patricia, I'm not sure. You said he's in Berks County, correct?
Yeah, he resides in Berks County.
So there's, I don't know if you're familiar with it, but COCA in Berks County.
Mm-hmm.
Have what's called the RISE Center there. And they do all kinds of programs there. They have a CRS on board right there as well. They do support education. They actually have a facility where he can just go there, and it's kind of like, I consider it like a drop-in center. They're right downtown Reading. It's called the RISE Center.
Okay.
Something that he could maybe engage in on his time, like trying to do some structure where there's other individuals there. And Brian is one of the individuals who runs that center. His name is Brian.
And do you know, are they doing anything remote right now?
They are. They're doing online as well for COCA. Yes. They do an awful lot. COCA is a huge program in Reading, in the Berks area.
They're the SCA for the whole community.
Yeah.
So, okay, that's great. Let's switch over, and we're going to do a short-ish version of the didactic. And then we'll move on to Brandy, who's got her case. Thank you, team. That was full of interesting things to consider. I think we'll have some chance to think about similar issues. While we're getting things on there, Gina, do you want to say hi? I saw that you joined us.
Sure. Hi, everyone. It's Gina from NHCLV, Program Coordinator. I'm happy to be here this morning, and thought this case was really amazing, and one of the more difficult ones that we have at the COE all the time is when you have someone who's kind of resistant to treatment yet showing up every day. And I think like confronting your own biases and some of your thoughts around that person is also like uncomfortable and difficult, but really important with doing that type of work.
Thanks, Gina. Yeah, I think it's the rich territory where the stuff gets done. And I see we also, Terry, you joined us. Want to say hi? Terry's on mute though. And Tommy?
Hi, good morning, everyone. It's Tommy Acevedo from the Family Health Center with Valley Health Partners. Great to be here. Thanks for having me.
Great to have you, Tommy. Terry, you want to say hi? We love the Terry stuff too. Not in a place to say hi, it looks like. Okay, go ahead.
Okay. All right, so I will be presenting on effective team-based care for opioid use disorder with focus on nurse-led model and care coordination and addressing social determinants of health. I have no disclosures. I have no disclose as long as call me. So a new law in 2000, so the Drug Addiction Treatment Act, is an amendment to the Controlled Substances Act, and it allowed physicians to prescribe scheduled medications that were approved for maintenance or detox purposes in the treatment. And then prior to 2002, there was no medication that existed for it, and methadone did not qualify for this, or does not. So for the collaborative care of opioid addicted patients in primary care using buprenorphine, BMC, Boston Medical Center, they put this together to see if they can bring opioid use care for and use the primary care setting using buprenorphine. So for BMC, Boston Medical Center, the office-based addiction treatment model, OBOT for short, so I'll be saying OBOT a bunch of times throughout the presentation. The nurse care managers, or the NCMs, they worked with physicians to deliver outpatient addiction treatment with buprenorphine and injectable naltrexone. And it was also called the Massachusetts model. So anytime you ever hear of that, it's because of this study. So for OBOT, they started in 2003, and through 2007, so over 7 years, they found that they ended up having about 425 patients with an average of 3 to 6 admissions per week. There were 9 physicians. 1 of them was a medical director. 3 of them were addiction certified, and 1 was, they were part-time clinical practices. So they each had about like 3 sessions per week. And then over those 7 years, it grew from just 1 RN to 3 RNs, a medical assistant, a program coordinator, and also a program director. In 2016, it grew again to 7 new admissions per week. They then had 17 waiver physicians, with 12 of them being certified in addictions and 3 sessions per week on average. They also had about like 5.5 full-time equivalents for an RN, 1 full medical assistant, and the program coordinator and director role went down slightly, but was still part of the study. So what they found was that for successful treatment, it was about 51.3%. So about half of them were treatment successful, and treatment successful was identified by adherence, so attending scheduled office-based opioid treatment appointments and complying with regular monitoring, including urine drug tests and pill counts, and any absence of evidence of buprenorphine diversion. and also any illicit opioid use. And then, as you can see, it was split between half and half, and unsuccessful treatment meant that with about 30% of them being lost to follow-up, the others were due to non-adherence. So this map was from 2015, and it says that 34,000 buprenorphine waiver physicians. Since then, the last time I checked the SAMHSA website, it's up to about 52,000. And those are for the providers that want to show up on the SAMHSA website as providers that are available. You get to choose whether you want to be up on that site. So there can be more prescribers that just aren't on the site, but still prescribing buprenorphine. So this study then went on to address the barriers. They surveyed some waivered prescribers to see what was getting in the way, or what was something that would keep them from prescribing buprenorphine for opioid use disorder. And what they found was that there was insufficient nursing support. Well, total they surveyed 156 waiver physicians, and they had a 66% response rate. So what they found was that there was 20% of them stated that they didn't have enough nursing support or office support. And then it went down into other reasons as like payment issues, insufficient institutional support, pharmacy issues. So that would be like your prior authorizations and just difficulty getting the medication. Okay. So only DEA waiver physicians and advanced practice providers can prescribe buprenorphine. So as of 2016, the Center for the CARE Act, I forgot exactly what CARE stands for, but it made it so that nurse practitioners and physician assistants can also prescribe buprenorphine with 24 hours of training. They can receive that waiver. So I think with the numbers that changed from about 30,000 to 52,000, partly because of taking down a barrier of who can prescribe it, so making the access more. The last map that I saw showed that in rural areas, they're still having a little bit of difficulty. And as we can see less like recovery supports and programs that are available in rural areas. So what makes the Boston Medical Center nurse care model successful? So with the nurse care managers, they're able to increase patient access because they can have more frequent follow-ups. They are able to be in contact with case management more. The nurses can spend more time with case management and also spend time with the patient. So there's more collaboration involved with that patient's care. And they're able to address positive urines, any insurance issues, any prescription or pharmacy issues. So that's always important. And then it also allows for providers to be able to take in larger caseloads. That way, with more collaboration between the provider and the nurse care manager, they're able to take in more patients and see them more on a frequent basis. And of course, that makes it so patients have less risk of being lost to care. The expansion of the Boston Medical Center office-based or OBOT model to the Massachusetts Community Health Center. So they found in 2007, they wanted to expand it to community health centers. And particularly because federally qualified health centers are mandated by the Public Health Service Act to provide mental health and substance use treatment and also provide direct services to patients. So they wanted to take this model and bring it into over 30 community health centers. It started with 14 and then it built to more than 30. So their main goals were access, delivery, and sustainability. For access, they wanted to have more number of waiver prescribers, and they wanted to increase the number of individuals being treated for OUD. And they wanted to integrate that addiction treatment also into the primary care setting. And that also changed their delivery, so they wanted an effective delivery model for buprenorphine, including the nurse care manager program and focusing on high-risk areas and underserved populations like those rural areas we discussed. For sustainability, they wanted to develop a long-term funding plan, and they wanted to be able that would be able to last. So to think about how to keep a program like that going for patients and also for prescribers. So this is another study, the office-based opioid treatment with buprenorphine, and it was a statewide implementation of the Massachusetts model in those community health centers. And the way that their treatment went, so patients would call in, a program coordinator would take the intake call, they'll screen the patient over the telephone, and then the team will review the case for their appropriateness, and then they'll meet with the nurse care manager and have an intake visit. They'll collect data, and then what happens then is that data is sent to the waiver prescriber, who will then do a physical exam, assess their appropriateness for buprenorphine or for the naltrexone, and then with the DSM make a diagnosis. The nurse care manager had a supervised induction on site, and then they managed stabilization on and off site, so either by phone call or by coming into the office. And they followed a protocol that included a patient self-administering the medication per their prescription. So they would follow that protocol, and all the nurses received training prior to doing this as well. The nurse care managers, they were registered nurses, and they completed that one-day buprenorphine training I just mentioned. They performed patient education and clinical care by following treatment protocols that were established prior to starting the program. So that include urine drug screens, pill counts, and any management for their treatment. This ensured compliance with all laws, and then they were able to coordinate care with all the prescribers and also with the team for care management. They had collaborative care with pharmacists in order to make sure that patients had their refills on time. And they also had drop-in hours for urgent care issues. So of course, things can come up, so they were able to be available to patients at all times, in hours that they specified prior. And then they were able to see on average about 75 patients per week. Maintenance treatment, patient care would stay for at least 6 months. So the nurse care manager they visit weekly for the first 4 to 6 weeks, and then they visit every 2 weeks, and then every 1 to 3 months as needed. And then the waiver provider was able to see the patient every 4 months. So as you can see, the numbers for cases could be a lot bigger if you have multiple nurses seeing patients weekly and then being able to see the provider every 4 months. They were medically supervised with withdrawal was considered based on their stability if they requested to taper. And then with transfer to methadone, if they had continued illicit drug use or they needed more structured care, so that would be determined as well. For University of Massachusetts, the study findings for Massachusetts, they studied 5,600 clients that were prescribed buprenorphine between 2003 and 2007, I'm sorry. And overall, their expenditures were lower than those with no treatment at all. And then clients on medications had significantly lower rates of relapse and hospitalizations and also ED visits. So that also lowered the cost for patient care. And then they found that buprenorphine was actually more of a choice for younger and newer clients to treatment. They saw that was more attractive to them. For the nursing assessment, this just talks about what was including in the nursing assessment that I talked about before. A lot of assessment of their history, so their medical history, their treatment history, if they've ever been to any treatment in the past, if they ever tried buprenorphine or MAT in the past, addressing any pain issues, mental health, current use, and a list of their current medications. They were able to complete consents and treatment agreements, and the treatment agreements includes multiple things, how often they're going to be coming in to see the team, any urine drug screens, and what behavior is expected in the office. And then it also included an understanding of the medication, so the potential for withdrawal if they were to start too soon. They should not use any other substances such as buprenorphine or alcohol while on treatment, and then basic rules for the office as well. So they would review these, they would sign copies, and the patient and both the office would have it. For education, they would have medication on the opioid, on the buprenorphine itself, administration, how to store it safely, and then the responsibilities according to the treatment plan. A urine drug screen is always taken, and then they would include liver function tests, testing for hepatitis, syphilis, a complete blood count and then also a pregnancy test for women. Then they would see the waiver provider, and then the waiver provider would review that history that was just taken by the NCM. They would complete a physical exam, assess those, the lab and the urine, and then make any decisions on treatment based on what they reviewed. And then they would also use the DSM again to make a diagnosis. And then they would determine if that was appropriate for office-based treatment, and if not, make recommendations to what they can do for their treatment. And if they were appropriate, then they would take the next steps in continuing their care. This is the induction preparation. So just the things that the nurse puts together prior to a patient coming into the office for induction preparation, and what type of things that they'll discuss when they come in. For the patient instructions on the induction day, they would make sure that one, the patient has insurance and they're able to pick up their meds. They want to make sure that they're able to pick up their meds and bring it to the office, because that's the way that they're going to get their induction started. And they want to make sure that they're disposing of any paraphernalia, any phone numbers or contacts, and then just to plan to be at the office for 2 to 4 hours, because this does take time, the whole process. So to make sure that if they need a support person, to make sure they have a ride, and to make sure that they have the time to stay in the office. The follow-up visits, they're assessing dose, frequency, cravings, withdrawal symptoms, and ongoing education. Education is part of every visit, and that includes dosing, side effects, and assessing that person's support. Counseling always checks in, so case management has multiple opportunities depending on where this patient is with their treatment. They can assess the need for any vaccines, planning for follow-up, any treatment for HIV or hepatitis C, and then making sure that they're overall just engaging with their care. This is a chart showing the average hospital admission per OBOT enrollment. So we can see that they're, over time, the hospital admissions went down from the prior 6 months to the next 6 months, and then even to the 7 to 12 month mark. Same for ER visits, you can see those decrease significantly with OBOT enrollment. And then social determinants for health for substance use disorder. So the health determinants contribute to biological and socioeconomic and psychosocial status. So we're all aware of what, or we've heard at least of what social determinants of health have to do with treatment. So, and all these include like the environment that we live in, whether we're employed or we have access to employment, we have access to health care, not just by transportation, but just by the physical locations. Is there any, do I have to drive 15 minutes? Is it a 15-minute walk? Is it a 2-hour drive? And can I get there? Any social stressors, so any abuse or neglect that's going on in relationships or in the home. Any mental health issues, and if they're receiving treatment for it. And then any cultural norms as well. So what's their attitude towards treatment for both substance use disorder and also mental health, if they have underlying mental health issues, and are they able to get some treatment for it? And then also decision making. Are they in a family that allows them to have like shared decision making? Do they do all the decisions themselves, or is someone else making decisions for them? So addressing the substance use disorder. So you want to take into account all of the cultural framework like we talked about before. You want to address that and make sure that you also have some compassion towards it too, and some understanding that these, although that's not necessarily all treatment, it still has to do with their treatment and can be a barrier or can also help depending on what it is. So can we change the environment? Can we encourage more schooling and job training? Use of universal health care, that way they can have more access to treatment by being able to actually get prescribed the medication and use it.
Something they have in Massachusetts, but not necessarily Pennsylvania. But
oh, yeah, right. Yes, not here. Sorry. for supports, parenting, education, counseling, involving the family, involving some peers, if the patient's comfortable with it. And this can help, and this can also not help depending on the situation. So you just need to gauge that. And then prevention and education. So what kind of connectedness does this patient have socially? And what kind of connectedness does the office have with the community as well? Even you don't have to just treat patients. You can also go out into the community and bring about some Narcan training, some training about substance use disorder. That way more people can understand it, and that way it can be accepted more in the community. For complex care management and opioid use disorder, patient-level outcomes are comparable to physician-centered approaches. So they found that their overall outcomes, although that the physicians weren't seeing the patients every week or every 2 weeks, as other offices, they were still able to withstand the same outcomes as if they did. This allowed for efficient use of physician time to focus on patient management, so that way they're able to see more patients by collaborating with nurse care managers and the team of case managers as well. And then it also increased the access, because even though there were less physicians, there was definitely more of a team, so they were able to take on more patients over a longer period of time and address multiple issues and not just substance use disorder treatment. Any questions?
So clearly, our teams aren't really set up this way, but it's interesting to know that this Massachusetts model has been a real inspiration, I think, for people across the country. And hearing Colleen LaBelle speak about this model in a couple of different places, I'm sure Jillian has too. What they were able to do to kind of inspire local level office-based treatment as a doable thing, and then to engage community health centers across Massachusetts in doing this care. I know that they were the inspiration for us at neighborhood health centers, even if we don't completely implement the same way they do. I think they've been a massive change agent for giving practices a way forward. And then, of course, they were instrumental in getting these echoes going too. But any thoughts? I know, Kevin, you've had different kind of nurse care management support. If you want to just talk about what's it look like for the nursing support, and what has that facilitated for you?
Yeah, so I've been fortunate enough to work with Amy Jean here at Hamburg. Just a very organized approach to taking care of prior authorizations, and together just regularly huddling so we can make sure that we keep on top of things. And so that's been really helpful. I would say that I haven't made the most use of Amy. Again, I'd like to see more patients in this capacity, and I think I know Amy would be a tremendous benefit to do getting in touch with Health Spectrum, and again with insurance changes, and just keeping everything sort of really well organized. A barrier would be that it's something that not every practice has an Amy, even a defined position. So not just the fact that she's terrific, but also sort of her defined position. And then also with staffing changes, Amy doesn't have the amount of time to devote to this that she had in the past. So there, it's that model looks wonderful. I know we have a different model, and then of course one of the challenges that we have moving forward is how to make that work. Who with clinical staff in our offices would serve that role? How much time could they devote to it?
I think you've put the hammer on the nail, so to speak. Right, and it is worth noticing, and some of the advances that they've made recently is how do they adjust that model so that they can provide real low barrier access to care, and they have a sort of separate drop-in center where they do that. But these are the center that Jasmine described is really an addiction medicine hub. which is something we're thinking and looking toward. How do we build that here in the Lehigh Valley? And lots of interesting conversation there that we'll have to take up another time. And then what does that translate to when we're in, if you're not looking at a high volume practice like the practice that they had where this is what they do, how do you adjust that? And that's an interesting question with the CCTs, like what parts of this are helpful and which aren't, but it's not the model that we have currently. But it's worth thinking about. It looks like a very successful model that's been sustainable economically, and they had the data to show it. So it's good to know what's out there and what other people are doing.
I say a lot of hospitals can take it as, like you said before, like inspiration, and then tweak it as what's best for every office is different. So it's all different.
And just to give Jasmine so much credit that you started with us and built the program at NHCLV so that we did adjust kind of to what we were able to do at the time, and having nurse care management present. You filled many, many different roles, lots of them described here, but keeping us organized and being the point of contact for people as they're getting started on their medications was really important. So thank you for all your wonderful hard work on that as you transition from nurse care manager role to nurse practitioner role. Really exciting. Any other thoughts or questions? And then we'll move on to Brandy's good case. Okay, we're gonna share the screen. Thanks for sharing that model with us, Jasmine. Okay, case number 2. So you just go for it. Okay, speak nice and clearly.
I will. Hi, I'm Brandy, and like I said prior, I am fairly new, actually very new. I began here at the end of July. I actually just started my caseload first week in August, and this patient, she is 34 years old. She's been here, again, I'm new to her, so she has been seen here for quite a few years, and she has 2 children, 14 and 16, and she was previously an OBAT patient, so she was receiving, correct me if I'm wrong, Suboxone for her opiate disorder. And as I'm looking back in her chart, in June, everything was negative. She had nothing positive in her system. So fast forward to now, I reached out to her my first week in August and no avail. It looks like in her chart, she continuously avoids every which way to come here or speak to BHI, or she cancels, or no, I'm sorry, she doesn't show up. She doesn't answer her phone, so she's very hard to get in touch with to begin with. I reached out to her on 8/3. She finally responded to me about 4 weeks later with a text message that she needed to talk. Obviously, I grasped at that opportunity, and I actually met with her for the first time at an urgent care that her mom was being treated at. And we met for the first time, and she was telling me how she is struggling with Klonopin. She purchased it from the street, and she told me that she takes as many as her body needs. So she's taking 1 milligram. She told me 3 times a day. The previous BHI told me most likely times that by 2 is probably the honest result, that she's actually taking more than 3 milligrams a day. When I met with her face to face, I saw her hands were shaking tremendously. She is very agitated very easily. She loses concentration and loses thought. She's very confused. I had a hard time understanding her, even sitting next to her, she doesn't stutter, but she definitely does not speak clear. Obviously, I think that is because she has so much benzos in her. So I actually trying to work with her as far as housing. I made a home visit just last week to check out her home situation. Everything looks good in her house. She's very clean, but she also tells me that she doesn't get out of bed till 2 or 3 in the afternoon. Meanwhile, her children are in their bedroom playing video games while she's sleeping. I did see some food in her house. I know she does receive SNAP assistance. I know her housing is free, and I also know she does have some cash assistance. I was talking to her in reference to reaching out to psychiatrist. She had an appointment she scheduled beginning of September. I asked her if she followed through that appointment. She says no, she did not go. I urged her while I was there to call Life Guidance and reschedule her appointment while I was there. And again, she's very agitated, very fidgety. She's very, very forgetful. She writes things down and she's shaking as she's writing these things down. I discussed patient with her, and as previously before, as BHI has spoken to her, she refuses at all angles. There's every excuse. It's my boys. I can't do that. I don't want to do that. I was homesick. I went there for a day or two, and she checks herself out. Come to find out, she went there, picked up a prescription, and her children were housed in Valley Youth House. She picked up her prescription from the inpatient and then left to pick up her children. So it seems that she doesn't necessarily obviously stay in inpatient. I asked her why, and she said she just can't be there. She doesn't like the way she's treated. Every excuse known to man that she comes up with. I finally got her into the clinic here on Friday. She has not been seen here since July. She had a phone visit, and she sat down for a good 45 minutes and spoke to the doctor. And every time the doctors would say, "What about this? No, I can't do that. No, I can't do this. No, I can't do that." So we are at loss with her. Following her appointment that day on Thursday, I walked outside with her and I said to her, and putting aside inside the clinic doors, I was trying to express to her how important her life is and her children, and that although she may be homesick after 1 month in treatment, that the end result is the most beneficial, and that's for her children. And I said, you know, your children are old enough to understand what you're doing, what they are going through, and how they're hibernating in their bedrooms at all times because you are sleeping or you can't have a full conversation with your children. I asked her if I could research some more and find a different type of inpatient for her. And as she was rolling her eyes at me, she's very, very reluctant. She's very, very guarded. I felt that I was able to press just a little bit more, just given that I have a better rapport with her now, because she does reach out to me quite often now. I asked her if she would let me just check different facilities for her, and she said, okay. So I left it at that. I sent her on her way. She did get prescriptions refilled. I did speak to her on Monday, and she said that she couldn't sleep. She had just woken up, and our conversation yesterday, she was...
Excuse me. I'm sorry, Brandy. I'm kind of lost. Where are we on the PowerPoint?
Oh.
I'm just, like, you're giving a great description. I'm just kind of lost as to where we are. Like...
So she has agreed to inpatient in the past, but left the days of. The Valley Youth House involves refusing inpatient admission. On Friday, she described as giving up, not being able to sustain from benzo use, and that was when she was speaking to the doctor. She did reschedule her Life Guidance appointment, and it's not until next week. And that's to see the therapist first, and not even psych. She did speak to her children yesterday as she was, I think she was in withdrawal yesterday morning when I spoke to her, because she was in almost like a panic state, because she said she needed to go to inpatient like immediately. And when I talked to her 10 minutes later, 15 minutes later about scheduling that inpatient, She told me that I had to wait. She had to wait because she needed children. She needed to figure out a place for her children because she wanted to leave them home alone while she went away. She told me she talked to her children about the inpatient, and she said, and her children said, you should have done that by now. And then after I spoke to her, she sent me a text message and said, can we wait till the 17th or 18th? I can let you know in the morning of. That's where we are. She did test positive for the benzo, and she also tested positive for Suboxone, but she does not have a Suboxone script active right now.
Yikes, right? Okay. Anything else, or
Is she continuing the Suboxone or no? Right now.
Sounds like she didn't get a prescription.
No, she
Okay.
hasn't one, and she's refusing.
Oh, she hasn't one.
So that's not really her goal, or necessarily ours either. Anybody out there who, I'm her PCP, I haven't seen her since July, as was recently mentioned. Anybody want to try a peer summary of that one?
I'm happy to do that, Abby. So this is a 34-year-old female patient at NHCLV. She has 2 teenage children with prior CYS and Valley Youth House involvement, but her children are a large motivator for her. She has a history of opioid use disorder on Suboxone in the past, and may currently be using street Suboxone, and is currently struggling with street clonazepam, taking a minimum of a milligram 3 times a day, possibly more, and appears to be experiencing loss of concentration, confusion, tremor, hypersomnolence, and has been struggling to keep contact and appointments, with a home visit last week that revealed some lack of supervision for her teenagers while the patient is sleeping. Her pertinent history includes depression, anxiety, asthma, and tobacco use disorder. And she has a history of attempts at prior inpatient treatment, but sounds like has typically left AMA due to not being able to tolerate the inpatient setting.
That sounds like somebody I know. Yeah. All right. Thank you, Jillian. All right. How about some clarifying questions from people? What else do you want to know about this beautiful, messy woman? Erica.
Has anybody ever talked to her about PHP, partial hospitalization?
You want to take that one? Or Brandy, if you know.
Yeah, I mean, she refuses everything. I mean, there's nothing, and if she refuses the day of, she forgets what I even mentioned when I talked to her the following day.
Okay. So does she have an active case with children and youth? I mean, is it like, so she's at Valley Youth House, but is it, I see that there's children and youth involvement, but because there is currently, is she in Lehigh County? Yes. There is a CRS that works in children and youth. So if at any time you want me to get her involved in this, I understand it doesn't need to be, discussed with the case manager. But if that's somebody that could be of help, I'm just throwing that out there. My question was about partial hospitalization. If she doesn't want to leave her children, or she doesn't like the inpatient setting, perhaps she can get inpatient treatment in an outpatient setting.
And do you have any insight onto when was the last time we talked to her about partial?
Did you say me, Abby? I didn't hear. You said me to answer that? Or okay. So as far as I know, the last time she was probably spoken to about partial could have been as soon as like 3 months prior to this. It's just been a barrier for her, like, speaking frankly. I think that she doesn't want to go to treatment. Like, she's in this weird place of ambiguity where it's like, she wants to change when things are bad, right? When she gets like the negative effects of benzo use. But when she's using, which is often, it's like there's no motivation for change at all. Even the fact that the boys are, you know, raising themselves, speaking to children and youth, they have had this case. And, you know, everyone who knows me here knows I'm pretty frank. I think they've done a terrible job. They have really not stepped in to enforce anything at all. They really didn't work with us that much. She had a program through Valley Youth House, which seemed like it was helping for a while, and then it kind of disappeared. So yeah.
I actually have a question. Do you know what program she had with Valley Youth House? What specific one she was involved in?
Go ahead.
No, I do not know since I'm actually new to this, but I did call Childline yesterday. Hopefully start up a new case just because of her behavior. When she first called me and speaking with her, it wasn't the person I spoke to last week. So I did go ahead and call Childline. I gave them as much information as I could. So I'm hoping that that will be followed up with soon. And if, you know, I cannot get her maybe, you know, into treatment, maybe reactivating her case, because I did talk to the previous PHI on her case, and her case with CYS is inactive. She does not actively have a caseworker.
Okay, because I was just gonna mention Valley Youth House, and this would depend on what she was involved in there, but Valley Youth House does have a specific program called Family Intervention Program, which is designed for kids at risk of maltreatment due to their substance abuse of their parents. So it would be a service that, you know, would be available to them. Just depends on what she was involved in with the kids through their offices.
I believe she was involved in that program prior. And she and the kids had a caseworker that would come out to the home. And as Brandy brought up, like, she's very much hot and cold where her participation lies in treatment. She tends to call when she's in a crisis or when she's very upset, and then otherwise she does not want to be bothered. And one of the reasons Valley Youth House stopped coming was they said she wasn't engaging in their treatment, which again, to me, does not make sense since it was through CYS. Like, so I would assume if you're not engaging in a program that CYS has put in place, that maybe CYS needs to revisit what's exactly going on in the home. And that wasn't done, and instead the case was closed.
Okay.
I'm sort of wondering, you know, when I hear the presentation, how things vary and she's disorganized, how much are we dealing with an undiagnosed bipolar disorder or primary psychotic disorder? I'm hearing that she can't sleep other times, and then she's just sleeping all day long. You know, I'm wondering if the use of the benzos are to try and slow down the racing of a manic sort of quality to her, trying to slow things down. The fact that she's unable to be motivated, is that because of some of the depressive symptoms as compared to, you know, willfully neglecting it? The other thing I wonder too, with the concern with, you know, watching over the kids, being careful with the kids, not wanting to leave them, I wonder if there's an underlying also the possibility of PTSD, if she's had trauma in her history, and is that a big problem, and she is using the benzos to help deal with the anxiety of something of that nature.
Yeah, she's had a boatload of trauma. Her mother was addicted to opiates. Her brothers have also been. She's disclosed to me at some points that mom would abuse her, or let people abuse her when she was a kid so that she could get high, or while she was high. And she still has a really contentious and abusive relationship with her mom. You know, her mom would call her while she was at the office asking her to lie to us and get Xanax for her. and saying she wanted Xanax for her birthday and things like that. And when she's had enough, she'll express that to us. But then again, she's also at the same time protective of her mom. It's a very bad dynamic.
So I just wanted to provide some clarification with CYS involvement. With my own history being employed by CYS, I believe one of the reasons why they probably closed the case is because these children are teenagers, and because they're teenagers, they're able to quote unquote care for themselves. They are able to voice any concerns to, and because they're school age, they have more eyes on them. I believe if she had 2 infants in the home, it would be a completely different story. I am not validating what CYS's choice to close was, but I'm just giving some clarification as to their thinking process. They probably thought that because there are more eyes on these kids and because they're school age and are able to be articulate, they would be able to voice any concerns. So I hope that helps.
I did find out that this is her son's 3rd year of repeating the 9th grade.
So it's probably a truancy case as well.
Kelly, you're on mute.
I was like, oh my gosh, 3 years in that same class, and the school hasn't made any kind of referral to children and youth or pushed this, because if she can get the kids taken care of and children and youth pushes a little bit to have her go into residential treatment and tell her, you know, hey, you're not getting your kids back until you complete, it gives her at least a leg up to have a better life for herself. With benzos, with who knows what else she's doing, and not knowing if the benzos are really actually benzos from the street, you know, this is dangerous. It's a very dangerous situation for her, and residential care is probably the best option for her.
Do you know which county she resides in? Sorry, Shelley, I didn't mean to cut you off.
No, go ahead, Sonia. That's okay, it's all good.
Oh, no worries.
Yeah.
Okay. I'm hoping that with the Childline referral you made, I'm hoping that they might do something called family group decision making. Depending on the family dynamics, sometimes it's really successful, sometimes it's not, but at least to avoid possible CYS involvement, they can sit down with the family and kind of have the frank discussion of what the family's concerns are, how they're able to support her, and possibly get her into treatment. Because if she's able to identify some positive supports, they don't even have to be family, they can be friends, they can be the next door neighbor, they could be, you know, anyone that the children identify as supports. That might be helpful, because it just sounds like she's really closing herself off, and there has to be an opportunity to just really start talking about what's been going on with her, and have the community wrap around her and try to support her getting her into inpatient, because it really sounds like she needs it.
Go ahead, Ken. You're on mute, though. Unmute. Still on mute. Oh, still on mute. Can you unmute him? No.
Mute. There we go. How's about now? Am I okay now? Okay. So I'm sort of wondering, as much as we'd like to get her in inpatient, I've seen very frequently these people who've been traumatized, and we don't know the extent to how bad this was in her. Getting them into a place where they feel trapped and have no control ends up almost being counterproductive. They will look to get out. That sense of lack of control in somebody who's been traumatized will be very difficult for her to tolerate. An intensive outpatient treatment program, partial program, yeah, where she has the ability to get home and not feel trapped, might be the first way. But it sounds like there is a whole host of trauma that I don't think we've even touched on. It sounds like, who knows to what extent she was used to get drugs. You know, it's unfortunately, you know, if somebody's been that traumatized, keeping them locked in a place will, they will just leave. They'll just leave. They cannot tolerate that sense of loss of control.
So Ken, while I do agree with you about the trauma, I mean, that's super, super important, but benzodiazepines and any opiate will kill her. And the withdrawal from the benzodiazepines is so horrible, where the anxiety level goes so high that she's going to want to bolt, whether it's the trauma or it's the withdrawal from the benzodiazepines. So she needs to be somewhere. I feel personally that she should be somewhere where she can be safely monitored, and try not to withdraw from the benzos at home, because when she tries to withdraw from them and the anxiety goes up, she's going to run no matter where she is. So, and you really can't effectively go after the trauma or try to heal that trauma until she's somewhat clean, you know, for lack of a better term, especially if she's using 6 milligrams or more a day. That's really dangerous.
Bill, I see that you joined us, and welcome for one. Second, let me just launch this question in your direction for a moment. This young woman, I don't know how much of the presentation you were able to hear, but Ken, you're right on target that she shows all signs of bipolar disorder with profound depression and then some very manic episodes. And she's absolutely self-medicating. She's been, we've maintained her on some of her psych medications from a previous psychiatrist in the past, and she was on some Latuda, and I don't have in front of me exactly what else, gained a lot of weight. She's done okay with that for a couple of years, actually. Her mental health symptoms were somewhat better controlled and she was using less benzos, but then it accelerated. We tried to get her inpatient for at least detox from the benzos. That didn't work. She was seeing a psychiatrist who was giving her benzos, and then we tried to wean her. That didn't go well either. And then we've been in this sort of crisis pattern, I'd say, for the last 8 or 9 months that have been really bad. Bill, and I guess Jillian, and this is also a question to you guys, because I think Ken is right that she hasn't been able to even approach being there inpatient. It's intolerable for her. What goes through your head, Bill, of how would you approach this person who hates herself when she's using the way that she is, knows that she's putting her kids through some degree of what she went through as a kid herself? Her most important thing was that she wants to be a better mother for her kids, and she knows that she's failing, so self-loathing all the time. How would you help her find a solution for getting out of this pattern, particularly with the benzos? She's done fairly well with the Suboxone for her opiate use disorder, but the benzo use disorder is the problem now.
I just wanted to, I'd like to respond to that, but I know Dr. Jillian, I'm just kind of curious in terms of like what's your take on the whole benzo piece of this, and what that is for her, as well as any mitigation strategies that you think might be important?
Yeah, so, you know, I think she's at risk, obviously, of seizures. It sounds like even when she was seen in the office, that she was tremulous, which would make me, you know, really worried about. I think she's probably escalating her doses to prevent withdrawal. And that makes outpatient options really challenging. Now, obviously, I think we have to meet her where she is, or this isn't going to work, right? You know, my mind wants to go like, please get this woman inpatient, right, immediately, but that may not work, right? It looks like that probably won't work. So one place my head goes to is to have her stabilized with something like a phenobarbital loading dose. Given the long duration of action, sometimes we can get people through alcohol or benzo withdrawal with a single dose. Occasionally they have to come back for an additional dose, especially with benzos, since their duration of effect is longer than alcohol. And for patients who absolutely won't go inpatient, that might be a harm reduction approach that would allow her to engage in a partial or IOP. I think she even doing so, she's still going to be at risk for seizures. I think my mind goes to her being at home with those kids, that she's at risk for seizing at home, right? Like they may be at risk for experiencing some pretty horrible stuff as a family if she continues to go through this cycle. So I think that that's something that could be offered to her, a phenobarb load with an outpatient plan. The risk is, of course, that she'll use benzos on top of the phenobarb. And that's a risk in talks that we're willing to take as a harm reduction approach if the patient is absolutely refusing all other resources. And that allows that patient to have a reduced risk of severe withdrawal and life-threatening seizures, et cetera. So that's where my head goes, that it would take sort of you could do a coordinated effort to do sort of an outpatient detox / combined with PHP or IOP. So what do you think, Bill, in terms of counseling options?
Unmute still.
I always mess that up.
It's my calling today to help you. Okay.
I obviously concur that the inpatient stay is the appropriate level of care, but that's not where the patient is, and I think it is important to go with where the patient is here. I'm really interested in that whole phenobarb piece of it because I am really concerned about those benzos, and I think that coupled with, like, if you have the availability of a partial and she will participate in that, or at least an IOP, gives the opportunity for that to be to maintain engagement with her and to be able to monitor and see how she is going and continue to work toward that longer term strategy of helping her understand. And she does. She appears to have that desire and that drive to be better at being a parent, to get her life straightened out, to manage well, as well as she possibly can through a program of recovery. But I think just maintaining involvement with her and at least offering her some of those other options would be really important. I think folks are working with her very well and trying to do everything they possibly can. But my concern would be, as stated earlier, if you push that too hard, especially as it relates to the benzodiazepine, that's going to just be overwhelming for her and not something that she's going to be able to even envision doing.
Thanks, Bill.
I don't know if that was much different or than anyone else has talked about, but I think the options are few in terms of where she is and what she's willing to, what we're able to do to help her at this point.
Ken, you're still muted.
I think we're still going to have to work on trying to get her mood stabilized beforehand. The Latuda, some of the second gens, maybe another mood stabilizing agent to help. I think that would need to be on board.
Okay. You broke up right at the point where you may have made a suggestion for the nice PCP.
Looking to consider a neuroleptic such as the Latuda, something to help lessen the intensity of the mood lability, because I think if we try to get her off that first, the lability of mood and as severe anxiety, the PTSD, she'll run. And I think getting her on something again like a second gen or a mood stabilizer will be imperative.
And I haven't seen, I'm not in her chart, whether she's still taking the Latuda. I know that she had sort of stopped at some point. Is there a sort of second suggestion? Because she was not really adequately managed with the Latuda alone, and I can't remember what else.
Is there a different name?
She was on.
you know, again, how motivated is she? I mean, the second gens can definitely calm down the anxiety. Abilify can help with the depressive components. Latuda can, Seroquel can. We've used some of the anti-seizure meds. I don't know if I would trust her with lithium due to its toxicity. But, you know, that would be, again, a way of starting. Again, maybe since she's having the sleep difficulty, the Latuda, Seroquel, something like that.
Yeah, and maybe, I think she self-DC'd the Latuda because she had some significant weight gain. And this was as things were sort of unraveling and she stopped coming into care. But we can try that again. And as far as a choice for, what would be your first choice if we were going to go with an anti-seizure med?
Since I'm here, you know, since she was not, I guess there was weight gain with some of them. I probably stay away from the Depakote because of that. And she's how old again?
34.
Okay. Any woman of childbearing years, I avoid the Tegretol and Depakote. So Lamictal or, you know, the lithium, but, you know, Lamictal helpful with the depressive components more so. But probably she would need, again, a second gen with it because it seems like there's some degree of disorganization in her thinking. As you said, she can't get her thoughts out. I wonder how much they're racing. And so Latuda, Seroquel, something like that.
Abby, I think she had Lamictal before and had some sort of reaction. I'm not 100% sure, but I feel like when she was coming to see us regularly, we had stopped Lamictal, or maybe that came from Step by Step where she came originally from. But I just wanted to say, I would strongly suggest, like, I believe that the psychiatric meds and treating the psych disorder would be really beneficial, but I would strongly suggest that she needs an ACT team in place to be monitoring her medications daily, maybe even coming out with a lockbox. Of course, that's difficult during the pandemic. I'm not sure how much they're coming out, but I feel like she needs that layer of support because she is not med compliant on her own.
Fair enough. Okay, fair enough. Okay, I'm going to have to leave at this point. Got some people waiting.
Well, thank you so much for joining us, Ken.
Sure. Oh.
Oh, Kevin.
Okay.
Hi, everyone. Question as far as like the family dynamic. Now that the sons are in virtual schooling, is there any family that could, house them for a couple of months while she possibly, you know, stays in touch with the COE, gets CRS in place, gets stabilized? It sounds like she still may not do inpatient, even if they're not in the home. And if so, then potentially following the recommendations from Jillian, but removing them and getting them in a safe space away from mom and grandma, and then getting her away from her mom, I think would be ideal. Maybe she can get linked with Conference of Churches, get her in her own space, get some rental assistance. There's a lot of grants available right now to assist with all of that. But I think really the only way of doing it that will help the entire family is by separating all of them right now.
No.
It's just not ideal in any way to keep them together.
There is no other family support. She doesn't have anyone. And her kids do go to school twice a week in person. And then they've already missed one day already, and they just started.
Yeah, but she really is profoundly isolated. I think, you know, only her immediate family have the only people that she's been in contact with, and I wonder how much shame has to do with that. And she doesn't feel like her kids are safe with her mom, but then she leaves her kids with her mom sometimes too.
Yeah.
But, you know, we see this, right? And know that people who are really struggling don't make a lot of sense. But we haven't been able to find any additional family support.
Yeah, so without family support, not children and youth, Valley Youth House may get involved once again with them and then possibly house them. I just would hate to see them go into a group home. And you know, like I don't know that that's ideal, but if there is no other family, that may be the only other place that's actually safer than where they're at.
That's exactly what I was gonna suggest, Yamalisa, because Valley Youth House has some transitional living programs, and you know, typically they're for kids aging out of foster care, but they do have a federal one where you guys, if the kids have had an engagement with Valley Youth House, that might be an option for them to do that and have some support that way while mom goes and takes care of treatment and whatever she needs to do.
Well, I wonder if anybody has asked the children who they identify as a support or who they identify they would be willing to stay with. I mean, it could be a friend, it could be a neighbor, it could be a distant relative. It doesn't matter as long as they identify somebody that they can stay with and that mom's okay with. That might be another option to help with some of the harm reduction and stabilize mom.
Sadly, the kids were so much without any support that they identified with our COE case manager and would call her all the time asking for help, even after hours.
Yeah, it's such a sad example of how the ACEs act intergenerationally, right? And how isolated this family has become as a unit and in service to this substance use disorders and the trauma. So a really tough one. I very much appreciate, thank you, Brandy, for bringing the case. She's one of my biggest heartbreaks. And this goes to show you this is the long game. So I keep some hope that even things that we've tried before that haven't worked, at one point when the moment is right, something's going to shift and will help her. So I just keep hoping for that. Let's shift to our checkout. Jasmine will be sending the recommendations for the case and really will those are so useful to see over the long term too, of what's the wisdom from this group. So my appreciation to all of you in the group, and we'll just do our kind of one word checkout. I'll call you as we go, and mine is deep gratitude. Valerie, you want to unmute and give us a word?
Those two cases were really, really interesting, and I'm just hoping that both patients do get the help and really, really get to where they want to be at. So thank you for sharing.
Kevin.
Hopeful. Hopeful.
Yamalisa. Thank you, Kevin. Yamalisa.
Hopeful as well. I think a little heartbroken all at the same time though.
Erica.
Probably hopeful. I'm going with, there's so many different things that I could come up with, but hopeful is the rounds it out.
Thank you. Patricia.
Grateful. You guys gave me some good ideas. Thank you.
Wonderful. Jill McCambridge.
Empowerment. I think one of our major roles is to help empower our patients. So that's what we're here for.
I like that. Sophia.
I think hopeful. I'm going to echo what Yamalisa said as well. I mean, it is definitely heartbreaking to see these patients where they're at, but you know, hopefully with some hope and some support, we can get them to where they need to be.
Sophia. Christopher.
I'm going with anticipation. I'd like to know what happens with these two people, and I wish them the best.
Thanks. Maybe we'll have a follow-up at some point. That'd be great. Shelley.
I'm blessed that we have such a wonderful group of people that can get together and share ideas. I think it's great.
Thanks, Shelley. Jillian.
I would say perseverance. And I'll mention Terry Norfolk Gibbons' comment in the chat box of strength.
Judy.
So cases with children always get to me. So heartbroken. I'm going to echo what Yamalisa said, but also just hopeful because of, we have a great group. So I know that they're in great hands.
Wonderful. Thanks, Judy. Diane.
Sorry about that. Thankful. And as my role, evaluations, please remember.
Do your evaluations. Perfect. Franklin. Unmute.
Here we go. I came up with village. I feel like we have a village here of great providers and skilled therapists that are willing to help with a lot of compassion. So yeah, we definitely have a nice village here.
Gina.
Interested, because I've been overseeing the case that Brandy brought up for the last better part of 3 years, and I'm really super interested to try some of the ideas that were put forth today, like from Jillian and Ken. So yeah.
Jessica.
Hi, sorry, I got pulled for something emergent that was happening here. My word is befuddled because I didn't have time to think of a word.
Befuddled. We can roll with that too, right?
Sure, sure. Engaged, there you go.
Wonderful. Erica.
Thank you for this educational process. For me, it's a blessed to see a compromised professional that are here to help other people that need this treatment.
Thanks, Erica. Jasmine.
Motivated.
Yeah, motivated. Okay, we got a motivated table going on in here. How about you, Brandy?
How about continued support?
Continued support. That's beautiful. Let's take all that words, big poem out into the world together and help this be a kinder, braver, wiser place. Have a great rest of the day, people, and we'll see you in 4 weeks. Don't forget to do your evaluations. And for those of you who've been with us for 3 sessions, hopefully you received a little incentive and presenters too. See you next time.